All right, it's 12 noon, and I think we'll go ahead and get started. I'm Conrad Lyles, Vice Chair of the Department of Medicine, and I have the pleasure today to introduce our Chair of Medicine scholars for 2024. So this is our annual recognition of our Chair of Medicine scholars. The Chair of Medicine Scholar Awards were created in about 13 years ago, and they were really established to help or assist in the or provide support and recognize individuals, promising young investigators who are making the transition from the senior fellow acting instructor status to assistant professor. And the support that comes from the Department of Medicine to facilitate this is financial. It's 50,000 times 2 years, or 100,000 in total, and that can be used for any of the aspects of the research that the individual who is receiving it would like it to go for. And our each year we solicit nominations for the Chair of Medicine scholars from the division heads, and then from that pool of nominees we select the recipients for the Chair of Medicine Scholar Awards. And this year we have two recipients. We have Dr. Bhatraju, who's an assistant professor in the Division of General Internal Medicine, and Dr. Simon Hsu, an assistant professor, Division of Nephrology. Dr. Bhatraju will give the first talk, followed then by Dr. Hsu. Please enter your questions for each of the talks into the chat function. And then David Rink, who is one of our chief residents, will then field those questions at the end, and then give those questions to the appropriate speaker and for their answers and discussion. So without further ado, we'll go ahead and introduce Dr. Bhatraju, assistant professor in the Division of General Internal Medicine, and she's going to give us a talk on buprenorphine for opioid use disorder. How can we get treatment to more people? So Ellie, I'll turn it over to you. I'll stop my share.
Great. Thank you so much. Let me share my screen. Let's start this. Okay, perfect. Well, let me know if that doesn't look good, but thank you so much for the introduction, Conrad, and for the opportunity to be here and present today. I'm really excited to share about my research and about the path to how I've gotten to this point. And so, yes, for the next 20 minutes or so, we'll talk about buprenorphine for the treatment of opioid use disorder and really kind of my career goal, which is how can we get treatment to more people? I have no disclosures and just a very broad outline, but we'll do a bit of background both about myself and the research, and then dive into some of the current research, things I've done at Harborview, and the current project I'm working on, and how that relates to implications and future plans. So just to take you a bit through my path, I've been in Seattle since 2014 and at the University of Washington since 2019, but have moved around a good amount before settling in here. And I've had great mentors at each of these places and don't really get an opportunity to express appreciation all that often. So I did want to put a handful of names as we go through. So I did my undergraduate at the other UW, or maybe this is the other UW, I don't know, but I was at University of Wisconsin for undergraduate, and then Emory University for medical school, as well as my MPH degree, and then went up to New York at NYU for residency in internal medicine, primary care, a chief year, and an addiction fellowship for 1 year there before coming out to Seattle and University of Washington, where I joined the faculty in 2019 and am now an assistant professor and also co-director of our Harborview Inpatient Addiction Consult Service, and also a research mentor with MedStar program, which is a NIDA-funded R25 that I did want to give a shout out to. It's a wonderful program for medical students and to improve the pipeline of people interested in addiction research. That the PI for that is Dr. Hsu, who's also my primary mentor. So there are many other people I could put on this list, but this has been part of my path to where I've gotten to now. And so that's my background, but I did want to spend a few slides also talking about the background of opiate use disorder and buprenorphine. It's what I do every day, but I know that's not the case for everybody. So just wanted to go through some basics to get everybody on the same page. And so it's hard to escape the headlines, certainly, and the numbers are striking. In 2022 in the US, there were 108,000 people who died from an overdose. That's nearly 1 every 5 minutes. And in Washington state, there were over 2,700 deaths. These at this point are primarily due to fentanyl, which is synthetic opioid. We can see this is a graph of the US numbers, and it really took off 2015, 2016. The gray is synthetic opioids other than methadone, which is primarily fentanyl. And then the orange and yellow lines are stimulants, either psychostimulants or cocaine. And we've seen different waves as things go through prescription opioids, heroin, fentanyl, and then now this combination of fentanyl plus stimulants. And that's what we're seeing here in Washington as well. So this is Washington state numbers from 2005 to about 2022. And again, we see a similar trend in overall overdoses, as well as in red is the fentanyl numbers, which really for us started a bit later than the East Coast, more so in 2019, 2020, almost at the same time as COVID. And then in green is methamphetamine. So I would say at this point on our consult service, this is the norm. We're seeing people who are using both fentanyl and methamphetamine. But people may have also seen this headline that overdose deaths for the first time this past year actually went down. Number of overdose deaths in the US decreased by about 15%. And so that is great news. And I think though there are still questions around that, why is that? Is it naloxone distribution? Is it something else? Is it just a blip? How can we keep that trend going in the right direction? And I also think it's interesting to point out that it's not across the board in every state a success story. So the pop-up box here that you see for Washington shows that actually in Washington, we didn't see a decrease. Our overdose death actually increased by 5%. So there's clearly still a lot of work to do, but at the same time, I don't want to paint a doom and gloom picture because this is the work I do every day, and I actually find it really satisfying and rewarding, and especially on the consult service where it is certainly possible. A lot of people who are working in the hospital may feel hopeless, helpless, very discouraged, seeing people who are so vulnerable and in a really rough spot. But I think on our consult service, we really spend time getting to know patients, building trust, being an advocate, and we're really able to start to see some change. We're able to get people started in treatment, and then we're lucky at Harborview, we're able to set people up with outpatient care right in our same facility, aftercare clinic, people transition to primary care. And on our team, we spend a lot of time highlighting and showcasing people who are starting to meet their goals, enter recovery in whatever form that looks like for them. And we do see a lot of success, and that really keeps us going. So I did want to just put that out there as well. And then, so diving into buprenorphine discussion, when we think about opiate use disorder, as opposed to some other substances, for opioids, medications really are the standard of treatment, and they work super well. There's really not a lot out there in medicine that works this well. So this is one study that is in that larger body of evidence supporting medications for opioid use disorder. So this is a study out of Massachusetts that looked at outcomes of overdose as well as opioid-related acute care use. This table is just focused on the overdose, but looked at, okay, if patients with opioid use disorder get on any of these treatment options, how do they do? No treatment is the reference, but then they looked at behavioral health options, intensive outpatient, naltrexone, and you can see that buprenorphine and methadone are the only one that significantly decreased the hazard ratio of overdose and decreased overdose at 3 months by 75%. So really dramatic decrease. And at the same time, we know that only 1 in 5 people with opioid use disorder are on one of these medications. And there's a whole nother talk and discussion about why that is. There's lots of reasons, but that's part of the reason why I've really gotten into this topic of, why is there this huge gap, and how do we get more people onto this life-saving medication? And so buprenorphine, again, this is medication I deal with every day, but I know that's not the case for everybody. But buprenorphine is a partial opioid agonist. It has very strong binding affinity at the mu opioid receptor. It's been approved for opioid use disorder since 2002. It's a Schedule III medication, and in the past, it required special training, either 8 hours for MDs or even 24 hours for PAs and nurse practitioners. In order to prescribe it, you had to get this X waiver, but that is no longer the case. So there have been some barriers that have come down. And this is a graph that I like to use for educating both patients and colleagues. We think about full agonists on the green line as methadone or morphine or fentanyl. And the more you take, so the more you go to the right on the dose on the x-axis, the more opioid effect you get. With buprenorphine, that's the blue line. It's a partial agonist. And the more you get, the more you take, the more effect you have for a bit, but then you level out or plateau and you have a ceiling effect, which is a very nice safety factor, where the more you take, you're not going to get benefit, but you're also not going to get respiratory depression, which is the scariest of the opioid effects. However, while that is a nice safety feature, it also creates a bit of trickiness in terms of starting the medication. So when we think about starting buprenorphine, there is concern for what's called precipitated withdrawal. And just to explain that briefly, so if somebody has full agonist in their system and they're up high to the right on that green curve, they've used fentanyl or they're on methadone, and then they take a dose of buprenorphine, because of that high binding affinity, buprenorphine will knock everything else off of the receptor and suddenly bring them down to that blue line level. And that will be very sudden, dramatic withdrawal with all of the withdrawal symptoms. It feels terrible. Patients describe it in very dramatic terms as like the exorcist is coming and, fluid coming out of every opening, and it's terrible. And we want to avoid that, both because it's terrible and because if someone has that experience, they're much less likely to be open to trying buprenorphine in the future. And we hear that from a lot of patients too. Like, no, I will never take buprenorphine again. It made me so sick. Don't talk to me about that. So we really want to try to avoid that happening. And so traditionally, the thought has been, okay, so you've taken a bunch of full agonists or you have full agonists in your system, you need to wait and gradually let that come out and drift back down that green line to the left so that you do go into withdrawal, but the opioids are out of your system enough so that when you take your buprenorphine, you come back up to the blue line and buprenorphine makes you feel better. And in the past with heroin or prescription opioid pain medications, that has been a pretty straightforward way to get people started. As we'll talk about in a second, it's gotten a bit trickier with fentanyl. Okay, so now I'll talk about just 2 studies around buprenorphine starts that we did here at Harborview since I've been working on our inpatient consult service. And one was looking at specifically trauma patients, but in the setting of a question around, is an inpatient stay the right time to start people on these medications and buprenorphine specifically? Or is it that patients are, maybe that's not the right time. Maybe we need to focus on what they're admitted for, focus on treating their pain, and then start as an outpatient. Or maybe people, they'll take it while they're here, but then they're never going to follow up. So we looked at patients that were seen by our consult service and started on buprenorphine for about a 1.5 year period. And there were nearly 200 patients that fit that category. And then we looked at patients specifically, like why they were admitted. And we found about 1/3 of hospitalized patients, 1/3 of those patients were hospitalized for traumatic injuries, which I think matches with what we see clinically. And we know Harborview is a big trauma hospital. And so then we looked at, okay, so we started all these people on buprenorphine, how many people came back? And we were able to get information for about 150 patients on whether they followed up within 30 days or not. and specifically followed up for buprenorphine care. And we found that 63% of trauma patients were seen within 30 days compared to 48% of non-trauma patients. And this was not, the p-value is 0.16, so not statistically significant, but it did lead to some discussion about, okay, well, trauma patients didn't have worse follow-up. We thought maybe they would. Maybe they're in too much pain. They can't, this is not the right time. But if anything, they came back slightly more often. And then we thought, well, maybe that's because they also had ortho follow-up, trauma follow-up, whatever it might be that would make them more likely. We do our best to kind of tag our buprenorphine visits onto other things that are already scheduled. So maybe that helps. And maybe actually this terrible car crash or whatever the trauma is a reachable moment where patients really are in a place where they might want to make a change or start thinking about a change anyway, or whatever it might be. And so we saw this as a successful outcome. And, while there's certainly still room for improvement, about 50% follow-up rate is it glass half empty or glass full? Maybe both. But yeah, so that was good to see. And then kind of following from that, we also saw, okay, so if we're going to start this medication for people in the hospital and for trauma patients, there are some barriers to getting it started. As we talked about with that initiation, we certainly were not able for a lot of these patients to do that traditional initiation where we would say stop all your full agonist opioids, all your pain medications, wait 8, 10, 12 hours, go into withdrawal, and then we'll start the buprenorphine. As you can imagine, for a patient who came in with polytrauma and has lots of injuries, they need to be treated for their acute pain, and it's not feasible, acceptable, or appropriate to ask them to stop all of their opioids and go into withdrawal in that setting. And so we were hearing about and seeing some emerging research around what was then called microdose initiations, or what's now called low dose initiations. And this was a strategy that people were using to start patients on buprenorphine while they were still using full agonist opiates. And that could be whether it was heroin or prescribed pain medications. And the goal with this is to very gradually, over about a week, introduce buprenorphine, starting with very low doses. A typical dose of buprenorphine is 16 milligrams. So this starts with 0.5 milligrams and gradually just gets the buprenorphine into the receptor, but without causing that precipitated withdrawal. And patients are able to keep taking their pain medications. And so we did start doing this, and it seemed to be working really well, but we said we should look at it. So in 2020, we did a retrospective study of the first year that we were using this protocol on our consult service. And we looked at all 62 patients that were started on low dose initiations. And then we looked at kind of why people were doing the transition, as well as were people successful? And if they were not successful, why were they not successful? And so the biggest reason that people did the transition was just that that's what they wanted to be on. Maybe when they came in, we weren't able to discuss with them if they wanted buprenorphine or if they wanted methadone. Maybe they got started on methadone, but then buprenorphine was going to be more feasible in the outpatient setting. Whatever it might be, it was patient driven. That's what they wanted to do. 30% of the time it was discharge placement. And this is a bit of a whole nother can of worms in terms of methadone and discharge placement, but methadone has been and still is a barrier to long-term care facility placement, like a SNF or something. Methadone has a lot of federal regulations and restrictions around how it is prescribed and dispensed. So we would get questions about, can this patient be transitioned to buprenorphine so that they might be placed at a SNF? And then a few times we had safety concerns, long QT or respiratory depression, where we thought buprenorphine, or the team thought buprenorphine might be a safer option. And what we found was that a large percentage, about 80% of people were successful. This was working well, and that's clinically what we were feeling and seeing. 51 out of 62 successfully transitioned and left the hospital with a prescription and a plan to continue buprenorphine. But what I wanted to point out here was that one of the biggest factors for people who were not successful was this reason for transition. And the biggest number of people who weren't successful fell into the category of post-hospital placement. So they were the ones who were, maybe preferred to be on methadone, but were transitioned to bup in order to try to get a spot at maybe a sniff. And they, like, would get 2 or 3 days in and then say, I don't think so. This isn't feeling great to me. Let's stop it. And so for us, that kind of reinforced this thought that really patients should be on the medication that works well for them and that they feel comfortable on. And it gave us also more data to support going and trying to be advocates for making methadone more feasible as an outpatient or as a option in SNFs. So that is an ongoing work on that department, but I think it does help to have data. Okay, so we got that pretty good and are still using the low dose initiations a lot in the hospital. But along comes fentanyl in 2020-ish and has made things a lot trickier. And there's a lot of work trying to figure out why that is. Fentanyl, for one, is very potent, 50 times more potent than heroin. And the thing that that is coming out that might be part of why it's harder to start buprenorphine when people are using fentanyl is that fentanyl is very lipophilic. And so while the effects of fentanyl are quick, they come on fast, they go fast, but it builds up in the body. The longer you use it, it builds up in the fat tissues. So when we think about fentanyl being on this green line, you can feel like you're starting to go in withdrawal, and people do, and it can be a day or two, but still you're actually up still towards the right on this green line and have fentanyl in your system. So when you take the buprenorphine, you go into withdrawal. And people there have case series and anecdotal evidence, anecdotal reports, people 2-3 days after fentanyl use, and they take a buprenorphine and they feel terrible and report precipitate withdrawal. So it's causing a lot of stress and complications for both patients and providers. And there's this tension that people are overdosing or having such high overdose rates. And we have this tool that can save lives, the buprenorphine, and yet we can't get enough people on it. So there's this feeling of urgency to figure out how are we going to do this. And so people have been trying lots of different things. Do we need to do all low dose starts for people who are using fentanyl? Or do we do high dose starts where we just go all in and give 32 milligrams of buprenorphine and maybe they go into withdrawal, but then that won't last too long and you just keep flooding with buprenorphine and get over the hump kind of thing. And there's not at this point a high level of data or research for any particular strategy. It's a time where this clinical practice is a bit ahead of the research. And so we need more research, which is why this is what I am now looking at. And whenever it was, August 2023, I was awarded this K23 Career Development Award, which is titled Building and Implementing Best Practices for Buprenorphine Initiation in the Setting of Fentanyl Use. So really trying to just learn more about what is going on now and why is it becoming so hard? What are people doing? What's working? What's not? And is it the precipitated withdrawal that's causing problems, or is it something else? These are my mentors: Judith Sui, Kevin Holgren, Gitanjali Chunder, Emily Williams, and Jessica Merlin, who is at Pitt. The first aim, which is what I'll talk about just for the last few minutes, is a qualitative study exploring the experiences of patients and providers. And then gradually over the next few years, we're going to develop a toolkit that will implement and assess. So the qualitative study, we're interviewing patients, 30 patients and 15 providers who have experience with buprenorphine, and trying to dive more into specific ideas around the effect that fentanyls have on buprenorphine initiations, and then using the analysis process to come up with barriers and facilitators using the consolidated framework for research framework. And just shout out to my research coordinator, Olivia, who has done a lot of work, and we have 4 more interviews to go, so we're making progress. The rapid analysis process for qualitative research. We don't do line by line coding, but we use templates. Each of us reads very closely each transcript. We have domains that we're looking for where we then put in key points and exemplar quotes. We make these matrix documents and then go through those to try to really synthesize the information and develop themes so that we're not just reporting back out, spitting back out what patients told us, but really synthesizing it and coming up with a new idea. And then organizing things by this CFIR framework. So this is where we are right now. As I said, we're finishing up interviews and we're very much kind of works in progress, but I wanted to share a little bit about what we are finding because we certainly we are hearing about the fear of precipitated withdrawal, but we're hearing a lot of other things too that are affecting people's ability to get on buprenorphine at this point when they're using fentanyl. And so, the third one here is a lot of people are talking about, especially providers, how it used to be so straightforward and now it's a mess. There's so much more nuance to it. And as this provider said, now it's like a little bit more of an art in some ways. Each person is a little bit different where they're with their use pattern and trying to kind of match that and support them in the best route to getting started. We also heard a lot from patients that the environment is really hard. Fentanyl is everywhere. And this thought that you have to wait a day or even longer after using fentanyl to start buprenorphine is just not feasible and people can't do it. And fentanyl is too cheap and too available. So this patient said, I can throw a rock and find somebody selling fentanyl right outside the door. I guarantee you, if I walked outside with a $20 bill, I could come back in 5 seconds with fentanyl. It's everywhere, everywhere. But at the same time, we also heard from patients that they do have trust in their providers and they appreciate the work people are doing. So this person said reminder calls and text messages, all that has really helped. And of course, the diligence and the staff, they seem to really love what they are doing, and that helps too. You don't feel ashamed of yourself as much, and you feel like these people really care and can help. And that has come out in every single interview, this feeling of feeling not judged, feeling like they are seen and heard is very important to the patients. And I will say also, every provider interview had some type of quote like this when we asked about their overall experience working in the field. This person said, amazing. It's my favorite job I've ever had. It's great. I love it. I love everything about it. So I wanted to that's the end, but I wanted to end on that because I do think the people that I work with are wonderful, and despite all of these challenges, it is really rewarding work. So our next steps are just to finish this analysis and then move on to the next steps of the grant and apply for future funding to keep getting more people onto this medication. So I will leave it at that.
Okay, thank you.
Thank you.
And remember, for the audience, please, if you have questions, put them in the chat function, and then we'll cover those questions at the end following Dr. Simon Hsu's talk. But thank you, Ellie. And then we'll move on to Dr. Hsu. And Dr. Simon Hsu is an assistant professor in the Division of Nephrology. And Dr. Hsu will be talking to us today about vitamin D and CKD, an unfinished story. If you have questions that you want Dr. Hsu to address, please put them in the chat. And then Dr. David Rink will go over those questions and pose them at the end of these talks, respectively to Dr. Bhatraju or to Dr. Hsu. So Simon, take it away.
Perfect. Ellie, great talk. And thanks, Conrad, and thank you all for being here. I'm Simon Hsu, I'm a nephrologist here, and today I'll be talking to you about vitamin D and kidney disease. And so over the next 20 minutes or so, I've really broken down my talk into 4 parts that chronicles my journey into nephrology and research. And I will start with my mentors and research interests. And so this is Virgil Woods. He is a rheumatologist and physician scientist that I met through a mentoring program as an undergraduate at UC San Diego. And together we studied, we used mass spectrometry to study proteomics. And even though it's not something that I'm working on now, he was really the person that jump-started my interest in research. And many years later at the same institution, UCSD, I met nephrologists and physician scientists, Joe Hicks and Dina Rifkin. And they really are responsible for me being a nephrologist and staying in research, and taught me kind of basic epidemiology, and we did a lot of fun projects together. It was also during this time that I learned about the vitamin D receptor and how, it's not just in the gut and responsible for bone health, that the vitamin D receptor has been found in nearly all cells in the body, including inflammatory cells and cardiovascular cells. And at this time, there were the mega trials of vitamin D that were enrolling patients like VITAL to see if vitamin D supplementation could be a magic fix for all these other ailments outside of fractures. And so I found that to be pretty interesting. And so knowing that patients with kidney disease have abnormal vitamin D and mineral metabolism, when I matched in fellowship at the University of Washington, I asked Dr. Ian DeBoer, a nephrologist and researcher here, to be my research mentor, and he agreed. And so since 2018, he's really been mentoring me in this field. So of course, shortly after fellowship started, the VITAL study came out, and it showed, that vitamin D supplementation wasn't the magic bullet. And so in over 25,000 general population adults compared with placebo, you can see the lines just perfectly overlap. Vitamin D did not have a beneficial effect on invasive cancer, cardiovascular events, and even fractures. Again, this is in patients with no kidney disease, general population. But I really think there are at least 3 reasons why vitamin D needs in kidney disease may be different. And these are reasons why I continue to be very passionate about vitamin D mineral metabolism. So number 1, the pathophysiology is so different. Mineral metabolism disturbances in CKD are severe and profound. So not only is it a matter of sufficient or insufficient vitamin D, you have disturbances in phosphorus, calcium, hormones like PTH and FGF23. So it really is a different, more complex creature here. Of course, many of you probably know that vitamin D is activated by the kidney. And so in patients with chronic kidney disease and patients on dialysis, they either have a reduced ability or inability to form activated vitamin D. And so this is very different from just plain old supplementation. And what this means is that the treatment of mineral metabolism and vitamin D disorders is complex. So not only do you have to consider supplementation, but you have dietary modifications, phosphorus binders, and calcium mimetics, and again, activated vitamin D agents, all of which aren't necessarily tested in the general population. And so studies in the CKD population are definitely needed. And so moving on to my work as a fellow, I've done a lot with Ian over the years, but one of the questions that we asked is there a better biomarker of vitamin D status than the 25-hydroxy vitamin D that we're all used to measuring? And there are many studies and lines of evidence that show that 25D is a great marker for vitamin D exposure and storage, but may not be for how much activity you have, and may not correlate well with human health. But I've chosen this study to really make the point. So this is a study of 25-hydroxy-D and bone mineralization in 675 European adults. And so here on the x-axis, you have the 25D concentration. And on the y-axis here is the proportion of your bone volume that is osteoid, so unmineralized bone. And so the lower, below this red line is adequate mineralization, and above is inadequate mineralization. So even though you can see that, the higher your 25D concentration, you're more likely to have adequately mineralized bone, what is pretty interesting is if you move this dotted line down to 10, which is considered severely vitamin D deficient, you still have more than 50% of participants who have achieved adequate bone mineralization, kind of suggesting that 25D isn't, a direct and best correlate of bone mineralization at the tissue level. And so that led me to study what we call the vitamin D metabolite ratio, or the VDMR, which may be a functional measure of vitamin D. and may better represent your vitamin D status. And to kind of talk about this, we need to briefly review vitamin D metabolism. And so many of us are probably aware that vitamin D comes from diet and sunlight. The liver then takes vitamin D and 25-hydroxylates it into the main storage form, 25D, which is what all of us measure in clinic. The kidney, as I mentioned earlier, converts 25D into 125, the activated form. And it is this active form that really circulates in the blood, goes intracellularly to activate transcription factors and promote its effects. Well, a less known pathway, which is nonetheless very important, is, this 24-hydroxylase pathway. And this pathway really exists to prevent active vitamin D toxicity. And so this works is when 125D enters cells and binds to, enact whatever activity that it's going to enact. It also upregulates its transcription of 25-hydroxylase, which then inactivates the 25D storage form into this 24-25 inactivated version. And by doing so, the more vitamin D activity you have, the more you're inactivating the precursor compound to prevent vitamin D toxicity. And so what we're calling the vitamin D metabolite ratio is really the ratio of this inactivated compound to its parent compound. And we think that, again, because this reaction is driven by 125 binding at the cellular level, that vitamin D, this VDMR, might better represent actual vitamin D activity at the tissue level. So with that out of the way, one of the first projects that I participated on, we called it the CLEAR project, which is a study of 25-hydroxy vitamin D clearance. And this is kind of the rough design. So in about 80 people, we administered deuterated or labeled 25-hydroxy-D at an enrollment visit after collecting blood and urine samples. And over the following 56 days after the infusion, we measured vitamin D metabolites. And so what you can see is that, as this labeled 25D is cleared from the blood, the concentration will fall over time. And so for each one of these 80 participants, we're able to generate this concentration time curve and calculate an area under the curve, which represents how much of the drug, or in this case, the administered vitamin D, is in the plasma over a given period of time. From this, we're able to calculate the clearance, which is, the volume of blood that's, the 25D is eliminated over time. And this is really a gold standard measurement of clearance for those of you who are into pharmacokinetics. And so with this in hand, we were able to test whether or not the single vitamin D metabolite ratio is really a valid surrogate of gold standard measured 25D clearance. And on the left here, we found that it was. The correlation coefficient was fairly strong at 0.51. And in this study, we were also trying to figure out, if you were to use the VDMR in future studies, what are patient characteristics that you might want to adjust for that might bias the VDMR? So stated another way, for two participants with the same gold standard measurement of 25D, does sex, race, ethnicity, these other factors, do they bias the VDMR in one direction or another such that you should correct it? And we found that race, Black race compared with white race, BMI, kidney disease, and serum albumin were factors that did bias the VDMR. And so all told, the conclusions from the study is, yes, the VDMR is a strong surrogate measure of 25D clearance, and that studies that use it should adjust for at least these 4 variables. One of the next projects that I wanted to look at is risk factors for fractures in kidney disease. So fracture risk is much higher in those with CKD and those on dialysis, likely because they have kidney-related risk factors in addition to traditional risk factors. And among those kidney-related risk factors is low vitamin D. And so this is a project that we undertook in the CRIC cohort. And our goal, again, was to understand what patient characteristics are really associated with fractures to hopefully be able to better assess fracture risk and develop preventative strategies. So this is the baseline characteristics of participants in CRIC, which is one of the most well-characterized CKD cohorts out there. And the whole main points I want to highlight is that it's fairly racially and ethnically diverse. And the mean GFR in this group was around 44 when they were enrolled. And down here on the 25D is what guidelines was actually say is deficient at 19 nanograms per mil on average. And so we, over a median follow-up of about 11 years, we found about 106 hip and spine fracture events in this group of 39 people. And we generated a whole bunch of tables where you have the risk factor that we're assessing on the left, and then on the right, the hazard ratio of fractures after adjusting for relevant characteristics. So for example, here you can see, per decade higher of age, your fracture risk roughly doubled. Similarly, down here, diabetes, patients with diabetes compared to not also had a doubling of fracture risk. And so we have a bunch of tables that I won't show you the whole thing. I'll provide you a summary at the end, but this is kind of how we assessed it. Looking specifically at vitamin D, not only did we measure the VDMR, but we also measured 25-hydroxy and 125-hydroxy-D. And so what we found is per 1 standard deviation lower of the vitamin D metabolite ratio, your fracture risk did increase by 17%, although, looking at the 95% confidence interval, it was not statistically significant. And so for these other metabolites, again, the directionality is there, but it did not reach statistical significance. And we have a couple thoughts as to why. One is our fracture event rate was kind of low at about 106 over 11 years. And so even though fractures are pretty devastating in this population and more frequent than in the general population, it's still a relatively low number of participants. So we might have not have had enough events. And second, we were actually able to measure the vitamin D metabolite ratio in less than half of the participants for financial reasons. And so, maybe if we had more events, longer follow-up and more metabolites measure, we might be able to have be able to detect a difference. And so, but this is a summary of our findings without showing the rest of the tables. And the ones in bold are risk factors that we have identified as fracture risk factors in patients with CKD. So moving on to my current work as junior faculty, this is my baby right now. It's a clinical trial called the DEPTH study, or the de-emphasized PTH study. And how I really have come to move into the clinical trial space is realizing the limitations of observational studies, namely confounding, and realizing that we really need clinical trials to answer some important questions in patients with CKD, including those on dialysis. So here's kind of the rationale and the setup for the trial, which is that, secondary hyperparathyroidism is a very common complication in kidney failure. And we nephrologists give activated vitamin D as a key component of therapy to try to lower PTH, which ends up being very common and costly. Some of you may know that guidelines suggest titrating, activated vitamin D to PTH and how much. They say, 2 to 9 times the upper limit of your assay's normal. And this really is just grade 2C evidence based on observational studies and expert opinion, and this guideline has stood for decades. And so you might wonder why this wide range of 2 to 9 times. And so I have 4 representative observational studies here to kind of illustrate a point. They're published in reputable journals, large N's, long follow-ups. You can see that the PTH inflection point for mortality in each one of these studies are very variable, likely due to confounding and differences in assays. So this first study suggests that over 400 is where you have a higher chance of mortality. This next one said 480, 511, 600. And so because of this variability and inability to really pinpoint down the optimal PTH has led to this broad recommendation of 2 to 9 times. So how does this really look in practice, and what have we nephrologists been doing for 2 to 3 decades? So this is the activated vitamin D algorithm that we use at Northwest Kidney Centers. And all dialysis organizations, Fresenius, DaVita, they all have their own internally developed activated vitamin D algorithm. And the gist is that every 1 to 3 months, you measure calcium and PTH. And depending on what your organization decides the optimal goal should be, you would titrate your activated vitamin D. And so to kind of walk you through this, a new activated vitamin D user who may have newly developed secondary hyperparathyroidism and started dialysis, first, you make sure that their serum calcium is not too high, because the main side effect of activated vitamin D is hypercalcemia. And so once you decide, the patient has adequate calcium, then you pick some starting dose fairly arbitrarily based on what their starting PTH is. So the higher the PTH, you might want to start on a higher vitamin D dose. From there, they're fed into this established activated vitamin D user algorithm, which again, every 1 to 3 months, you check calcium and PTH, and you basically have one of 3 outcomes. One is that you give too much activated vitamin D and the patient gets hypercalcemic. And so at that point, you hold their activated vitamin D and you wait a month and you check labs again until they're back to baseline and then restart. You might have given too much activated vitamin D, on the other hand, their serum PTH is too oversuppressed, at which point we're defining it at Northwest Kidney Centers as less than 150, at which point you also hold your activated vitamin D. And then a third possibility is you're within our recommended range, about 150 to 600, and depending on how rapidly you increased or decrease or stay the same, you might adjust the dose slightly up, down, and that's a separate algorithm that isn't really shown here, but that's how, again, us nephrologists have been prescribing activated vitamin D for a couple of decades now. And so why am I really challenging this dogma of PTH-targeted activated vitamin D? Well, I really think that for every potential benefit, there are hidden risks that we might not know precisely because there are no randomized trials in this space. And so these are some of them. So on the left, we presume that lowering PTH, you have a mortality benefit. But activated vitamin D actually increases the concentrations of this hormone FGF23, which is thought to be harmful and critically was discovered many years after PTH. And so what is the balance between titrating activated vitamin D to lower your PTH at the expense of increasing this FGF23? There are experimental studies showing that you need some amount of vitamin D to prevent vascular osteogenesis, or the formation of harmful bone cells from vascular smooth muscle cells. But again, you give too much vitamin D and you get hypercalcemia, which is the main side effect, and hypercalcemia may drive consequent vascular calcification. Lastly, you need vitamin D to improve high turnover bone disease. But like I mentioned before, if you overdo it and the PTH becomes oversuppressed, you get adynamic bone disease, which is actually the most common bone disease in patients on dialysis, which also predisposes to fracture. And so that leads me to this de-emphasized PTH trial. It's a pragmatic randomized trial, which means it's built into routine clinical practice. We're targeting 90 participants with secondary hyperparathyroidism, and this trial is only possible in partnership with Northwest Kidney Centers. And the idea is that 45 people will be randomized to usual care, so treatment per that algorithm that I just showed you. Then the other 45 will be randomized to a low-dose activated vitamin D. In this case, we're choosing to use oral calcitriol. And we're targeting a more liberalized PTH, PTH less than 800. And so our hypothesis here is that compared with the usual care, the low fixed dose activated vitamin D strategy with a more liberalized PTH goal will have superior effects on biomarkers associated with bone and vascular health over 12 months, which is the trial duration. And so I have some preliminary data here to share with you. So we started enrolling patients in March at 2 of our 20 Northwest Kidney Centers, dialysis centers. And what's nice, because of the EHR, we're able to fairly efficiently screen people. And so in these 2 centers, 272 people were screened for eligibility. And ultimately, so far, we have 39 randomized. So we're about halfway to our target. So showing you some baseline characteristics here. So again, low dose calcitriol compared with usual care. And about halfway through, to our target, most of the characteristics are balanced. If you squint a little, maybe the low-dose calcitriol group had a higher starting PTH compared with usual care, but everything else is roughly equivalent. And sharing you some preliminary follow-up data that we have. What's nice is that we've achieved one of our main goals, which was to achieve PTH separation between the two arms. And so in the low dose group, we found that indeed, so far, the median PTH is much higher. It's about 650 compared with usual care at 386. The calcium and phosphorus so far, not too different. And I'll just say, to my surprise, no one in either group have experienced hypercalcemia yet, which is not what I've expected based on my own dialysis patients. But again, the median follow time for these participants so far is maybe about 4 months or so. So there's still time to go. We're halfway through enrollment. The primary outcomes the primary outcome for this study is the 12-month change in this FGF23. And we're also looking at some other biomarker outcomes, serum calcification propensity, which is a novel marker that purports to measure exactly what its name suggests, and then bone formation rate via the bone-specific alk phos. And so we haven't run these assays yet, and these serum samples are sitting in a freezer in our lab, but we'll hopefully be able to make some important discoveries with this trial. So closing out here, these are some implications and thoughts I have about my trial, which is that I hope that it provides some clinical evidence for or against PTH targets in dialysis. And certainly it'll offer some preliminary data for larger clinical outcomes trials that are needed to conclusively inform whether we should continue to target tight PTH ranges using activated vitamin D. And lastly, pragmatic trials are a way to save money and maybe more generalizable than traditional trial designs. And so this can really expand on pragmatic trial experience in dialysis in a time where clinical trials in nephrology are conducted less frequently than in other medical subspecialties. These are some of the other things that I plan to do in the future. I mentioned trials in kidney failure, so kind of an extension of depth. And in partnership with Northwest Kidney Centers, I'm looking at potentially doing other interventional studies, including how to optimize a dialysis prescription. One thing that I found, and was also part of my K23, is that the Northwest Kidney Center patient database is really a rich resource that no one's really used, that has really key real-world data that one can use to perform observational studies. And so a goal of mine is to build a database using this real-world Northwest Kidney Centers data to do pharmacoepi studies in mineral metabolism and even other work outside of this area. So to conclude, the vitamin D metabolite ratio we found is a strong surrogate marker of 25D clearance. And I'll admit that it was more promising of a therapeutic target than I thought, but that, right now, based on what we found, testing and treating to either VDMR or even 25-hydroxy-D and CKD populations to assess fractures or cardiovascular disease, this is some data that I haven't shown here, but something that we studied, are not currently well supported. Pragmatic clinical trials in nephrology are really needed, and by leveraging existing healthcare infrastructure and patient-provider relationships, they may really reduce trial costs and enhance external validity. And in closing, I have so many people to thank for my success here, or they're here. And I'll just shout out my primary mentor, Ian DeBoer. Thanks so much.
Fantastic.
Thank-
Thanks, Dr. Hsu.
Dr. Hsu, thank you. I'll turn it over to David now. So David, I think you'll field the questions right in the chat.
That's right.
Okay, good.
And I'll start with a question for Dr. Bhatraju, which is, would you be able to discuss maybe more broadly any limitations to the work clinicians can do to address opiate problem at scale? Or reframed, Are there investments and or other regulatory changes that city, state, federal agencies can affect that could enhance the work clinicians do?
Great question. Yeah, I think probably lots of things. And there is a lot of work going on at all of those levels, certainly, and people trying to figure out how to make a dent in what's going on. Like in Seattle, the public health department is working with the city, making treatment more available, having a lot of low barrier options, even having the EMTs are starting to be able to carry or already have Narcan, but buprenorphine itself, and starting that in the field if somebody has an overdose and then doesn't want to come to the hospital. So I think overall thinking about like how do we make treatment needs to be easier than getting fentanyl, right? As that one other quote said, like it's too easy to get fentanyl. How do we make buprenorphine easier? Is it low access or low barrier clinics, going out into the field more where people are, meeting them there? I think buprenorphine it's covered by insurance. I think that's not a problem. I think the issue I mentioned around getting methadone, there's still a lot of regulations there. I do think there's been some movement forward. COVID actually may be a silver lining. There were some changes made to regulations for both methadone and buprenorphine that made it easier for people to get started and stay in treatment, telehealth options, getting more take-home doses with methadone, and those have now been made permanent, which is great. I think one thing I didn't bring up much about is long-acting injectable buprenorphine options, which are available now. And that's something we're working on, trying to be able to give those on the inpatient side. As somebody leaves the hospital, give them a shot of buprenorphine that will last a month. And there are some regulatory issues there with insurance coverage. So that's one thing. I don't know how this would fit in exactly, but stigma is still a huge barrier. And so any impact we can make there, and sort of internal stigma as well. I think a lot of these, 4 to 5 people who are not on these medications, some of those people say they don't want treatment. And then to me, that then begs the question, well, why not? And is it because treatment is not appealing, right? So how do we change the treatment so that it is appealing? Because most of these patients, it's not that they don't want to keep using fentanyl and being in the situation they're in. They just don't want, we make it very hard to jump through the hoops of the treatment.
Fantastic. Thank you for your thoughts there. I'm going to jump back to Dr. Hsu and with a question about why not measure 1,25 dihydroxy vitamin D routinely rather than the 25 hydroxy vitamin D?
That's an excellent question, because it would almost seem logical to just measure the activated compound. The 2 main reasons: one is that it actually concentrations, most people are very tightly regulated, and so they don't reflect either vitamin D exposure or the activity. You'll recall that the 1-alpha hydroxylase in the kidney is the one that does conversion, and there are compensatory mechanisms such that someone might be deficient in vitamin D, but to make up for the 1-alpha hydroxylase is revved up. And so in deficiency, you might have higher concentrations on 125D that doesn't necessarily represent, what your body storage, vitamin D storage are. And the second part of that too is the concentrations of 125D circulates at much lower concentrations, so about 1,000-fold lower than 25D. So the assays are just not precise enough. But it's a great question.
Fantastic. Thank you. We are short on time. I'm going to try and squeeze one more question in each here, but I'll ask you guys to just kind of keep your answers focused if possible. So I'll stick with you, Dr. Hsu. Another question about the role of vitamin D. Any comments on vitamin D and its role in immunity and host defense in these patients?
Yeah. So I'll keep this brief. So I think vitamin D is very key in inflammation, immunity, host defense, all of these things, and they're absolutely necessary. But I think that we are overdoing it with supplementation, and that most people have enough vitamin D and you just need a little bit for all of these things to work. And so if you're asking me broadly what I think the target should be, most people are going to be fine with 20 nanograms per mil. And so as long as if you're below that, you're in Seattle, you get enough sunlight, You might want to supplement, but once you hit 20, the benefits are not there. And if you get significant higher, you might have risks like hypercalcemia and kidney stones.
Fantastic. Thanks. And then one last question for you, Dr. Bhatraju, which is, given the dynamic nature of the drug supply and substance use in general, for example, we've seen eras of oxycodone, fentanyl, addition of adulterants like xylazine. How do you endeavor to generate evidence-based treatment strategies that remain current?
Yeah, great question too. Who knows what's coming next? I mean, I think to me, it's more the treatment setting and the stigma, really, right? Because things are going to change in terms of what the medication might be potentially that we need, or not, or medications that are available, but building a system where patients feel comfortable coming in and talking to their providers, and providers feel comfortable talking about it with patients is probably going to be the kind of base that we need in order to respond to things that change.
Fantastic.
Hey, David, could I make a plug here for
Sure.
behind Ellie's after Ellie's talk? There's an excellent book if people are interested in the evolution of the opioid epidemic and the reasons behind it, called Death in Mud Lick. And it really is by a journalist who examined the factors that were involved in the rise of the opioid epidemic in West Virginia and Kentucky. It's really an excellent analysis of what was going on and what fed into that epidemic. So I just wanted to do that plug because it's by a journalist from Charleston, West Virginia, Death in Mud Lick, but it really details all the problems and the factors that went into this spiral, into this epidemic, at least in Appalachia. Okay, well, thank you, Dr. Bhatraju and also Dr. Hsu. Very nice presentations, and thank you all for attending. See you later.
Thanks, everyone.